Hello, and welcome to Don't Hate Ventilate, a new podcast about respiratory therapies and the students in the Weber State University 2020 graduation program. Um, we are four dudes that have been in this program for a year now and have been learning all sorts of fun topics about respiratory therapy, and we are here to teach you more about the field and what it's all about. Um, we should do some introductions. First up is I'll introduce myself. I'm Nick. I got into the field of respiratory as a former childhood asthmatic. I've been in the hospital multiple times for asthma exacerbations, and after knowing my whole life that I've wanted to be in the medical field helping people, when I really when I sat down with a career counselor and they talked to me about my options, I remembered all the therapists that helped me through the years, and it just seemed like a natural fit for me to pass things on. Um, and yeah, so let's go to one of the other co-hosts, Drew.
Yeah, like you said, my name is Drew. I am also a student at Weber State, and I have about 6.5 years as being a CNA. So I've been in the healthcare field for quite a while. I too have a lot of family members that have had a lot of asthmatic problems throughout my childhood, and so it's been fun to kind of learn what has happened to them when they had like an exacerbation and things like that. But what got me really into this field was working with a lot of the nurses. They always seem pretty unhappy with their job. They don't really seem to really like nursing. And but one day when I was going talking to my guidance counselor, because I originally was going into nursing, they advised me to check out respiratory therapy, and I honestly asked him like, "What the freak is that?" And he described it more essentially as it's nursing without the butt stuff. And so that kind of piqued my interest because being a CNA, you get down and dirty a lot with these patients, and uh, took that introduction class to respiratory and ended up loving it.
Let's go with Tom.
Hey, so my name's Thomas. As what has been said before, I'm in my second year of the respiratory therapy program up at Weber. Looking back on my education up there, I am going to be there long enough to have been a doctor, and I've kind of dabbled in a lot of different healthcare fields like radiology, EMT. I've even done like intro classes for nursing, as Drew was kind of talking about. But yeah, the reason why I went into respiratory was my firstborn. He was in the NICU for 2 weeks. Nothing against nurses, but they didn't really talk to me much about what they were doing. They didn't include me in cares. The respiratory therapist actually got to know me. He's like, "Oh, you have medical background. Like, do you want to know what I'm doing? And do you want to help out?" And that just put me at ease. And that's kind of why I want to go into respiratory, is to hopefully eventually work in the NICU and help parents realize that what we're doing is for their kids' best interest, and to let them know it's going to be okay, kind of because I made it through. So, and that's me.
My name's Trevor. I'm also in the respiratory therapy program here at Weber State. Um, I grew up like with all of my job history. I was started out as an electrician, and I really like the hands-on things, but I've always been drawn towards the medical field for some reason. I got an opportunity to come work for a home care company where I was delivering medical equipment to people's homes. And I just really kind of fell in love with the patient care aspect and like getting close to patients. And I had a manager who was a therapist, still is, and he just kind of helped nudge me in the direction of respiratory therapy. He set up a job shadow for me up at a hospital somewhere where I was able to go and walk with a respiratory therapist for an entire day, kind of see what they got to do, see their day to day. And it really just felt like something that I could do for my whole life and be happy with. As I kind of looked into it, I found up at Weber State there was a program here, and I just started doing everything I could to get into the program, and have loved it ever since.
All right. Well, and now that we've introduced ourselves, I feel like it's appropriate to explain more about what respiratory therapy is. Most of you listening haven't heard about the field at all. You've probably only heard of nurses and physicians in the hospital. Those are the main two patient care specialists that you see. But respiratory therapy is actually there too, and it's pretty prevalent. Any disease that involves the lungs, the kidneys, the heart, we're there helping make sure that you can breathe and to help keep you alive. We're mostly focused around emergency medicines, but we're also there for maintenance, for smokers, asthmatics, people with chronic pneumonia, bronchitis, emphysema. All of these diseases require constant interaction with respiratory therapists, and the field is really blossoming in the unfortunate circumstances of the COVID-19 pandemic, which is currently in full swing as we are recording this episode of the podcast. Now, we're going to each go through a couple of parts of the field and, what we use these parts for and kind of what you would expect to see a therapist doing on the day to day. So, first up, tools we have as therapists is using data to help patients. We use data constantly in the medical field. We are constantly diagnosing patients based off of certain values that we measure. And respiratory therapy is the exact same thing. Now, we, of course, mostly focus on the lungs, as is in the name, respiratory therapy. So there are a couple of values that we look for and a couple of diagnostic tests that are just key for us to diagnose and treat patients. And the first off is arterial blood gases. Now, arterial blood gases are just the elements and, well, gases that are a part of your blood dissolved in it, and they reflect directly what your lungs are doing. Um, Now, we do this by taking a sample of your arterial blood through a couple of sites that we'll talk about later. But within these blood gases, we put them in a machine, we take the blood, put it in a machine, and then we run it through the machine, and it will spit out a bunch of values. Now, the values we specifically are looking for as therapists are the CO2 content, the oxygen content, the pH or acidity level, the amount of bicarb in the blood, and the hemoglobin value. Now, we use these all to assess how much you are breathing, how well you're breathing, whether there are any additional systems that are affecting your lungs, and just how the blood is doing. These are all super key when it comes to diagnosing and treating a patient. Also look at the lungs themselves for a couple of values to assess the strength and status of both the internal parts of the lungs as well as the diaphragm. Now, the diaphragm, for those of you that don't know, is the major muscle in your chest that controls your breathing. Every time it contracts, it causes air to go inside your lungs, and every time it relaxes, it's what causes you to exhale. So that the diaphragm is pretty much the key way that you breathe. Without it, you wouldn't really be able to breathe. Now, some of the tests we can do that assess the lung function itself is we look at a value called dead space. Now, dead space is the areas of the lung in which oxygen isn't being exchanged with the blood vessels that surround your lungs. It's areas of your lung that when you breathe in and breathe out, oxygen isn't escaping. Nothing's happening there. Now, everybody has natural dead space. It's a good thing. It doesn't cause any problems, but we need to assess to see if there is more dead space than there should be. So in cases like pneumonia, the amount of dead space will be increased. Also have tests that assess the strength of the diaphragm, how easily it is contracting and relaxing and pushing air in and air out. We of course need to know this because if your diaphragm isn't strong enough to actually contract and bring air in, you can't breathe. You would be going into what we call respiratory failure. And as the name suggests, not something you want, by far. Another big key that we have in our tool belt is chest x-rays. Lord, oh Lord, do we love chest x-rays. You can see so much and diagnose so many different diseases just based off of a chest x-ray. Most commonly, we are looking at AP chest x-rays, which are front to back chest x-rays. And we are looking at them for a couple of different things. We're looking for any, haziness, which on an x-ray, anything that is white is fluid or tissue that shouldn't be there. What we want to look for in the lungs, specifically on a chest x-ray, is we want to see nice gray, dark gray, or black areas. That's where the lungs and the air is actually at, instead of these white patchy areas that could be consolidation, could be a tumor, it could be blood, it could be so many different things that we don't want in the lung, because if they're there, you can't breathe right. And you won't feel well. And it could potentially be life-threatening. So chest x-rays, huge tool that respiratory therapists have. We have just visual appearance of the patient. Whenever we come into a room, any health provider, we are just looking at you to see how you're doing. You'd be amazed at how much we can tell about your health just by looking at you. We can look at your height and your weight and your age, your body type, color of your skin. All these things we can use to help diagnose you and properly diagnose you, because without viewing these things, we don't get the whole picture. Otherwise, it's just a bunch of numbers that, we can make some pretty good guesses on, but without visually seeing you in person, or at least pictures of you, we can't diagnose you properly. We would not be able to catch the right things. One big thing we're monitoring when we are looking at you, or when you are in a hospital, is your respiratory rate. So your respiratory rate is simply how many times you're breathing in a minute. Normally, with a respiratory rate, we're looking between 8 to 20 breaths per minute. It doesn't seem like a lot, but it works perfectly for us humans. Now, there are a couple of different types of breathing that we look for that, can be indicative of something. Whether you're breathing very slow, which we termed as bradypnea, or if you're breathing very fast, which we termed as tachypnea, or hyperventilating, which is hyperpnea. All these, fancy terms are just tools and descriptions of things that we look for and can use to diagnose you. Another huge tool that we use frequently is listening to your lungs with a stethoscope. So we literally just put the stethoscope up to your chest and we tell you to breathe, and we can hear different things that are completely different than normal lungs should sound. And, we can diagnose off of that. If we hear wheeze, it could be the parts of your lung called bronchi constricting due to an asthma episode. Or we could be hearing a kind of wet, coarse sound, which could be fluid in your lungs. We could hear crackles in your lung, kind of like Rice Krispie treats going being crunched, which could be the little air sacs in your lungs called alveoli collapsing, which means you're not taking deep enough breaths. We listen to breath sounds to help with our diagnosis, and just it's a huge part of it. The electrocardiogram, it's not something we directly interact with, but it's something we also look at as medical professionals. We need to know how the heart is doing because in a life-threatening situation, we're there too. We are there making sure you breathe while everybody's doing CPR on you. We are primarily an emergency field. Respiratory therapists, when you go down crashing and you're unconscious and you're not breathing, we're there to breathe for you. It's it's one of the biggest, and it's a scary part of the job, but it's what we're there for. It's why so many therapists get into the field. Now, finally, the last big tool that we have under our tool belt is the pulmonary function test, or PFT. Now, pulmonary function test is a very big set of words for simply just measuring the lung. All we're doing with PFT is just measuring how much volume the lung can take of a given gas and how slow or fast that gas can escape from your lung. PFTs are done by specialized respiratory therapists that go on to get their PFT credentials. And what they do is they will give you a gas that they can measure, and then they will tell you to do various maneuvers to expel the gas out. And by doing so, they can measure, how much of that gas got in your lungs. That would equal how big your lungs are, or how much gas got out in 1 second. That is a good indicator of, do you have air getting trapped in your lungs, which happens in COPD. It's a huge part of respiratory therapy, and it's very important. We need to be able to know how much volume your lungs can handle, and we can calculate it all we want, but to really be sure, the PFT is a great way to go. Well, now that these were some of the data tools that we use and some of the data values we look at when diagnosing and treating a patient. But, you know, Trevor here is going to talk a little bit about what we actually do with this data and what sort of treatments we can perform.
Yeah, thanks, Nick. Yeah, so it's one thing to be able to look at data and interpret that data, and it can be very useful. But the next step is actually knowing what to do with that data, and that's where it comes in. As a respiratory therapist, we basically break up our levels of importance of like what we're going to fix with the patient first, and then we have like a pecking order. And we separate these into 4 separate categories, dealing primarily first with ventilation, second with oxygenation, third with circulation and perfusion, and then fourth being like any underlying causes. So I always focus on ventilation first because that is considered the most important. You can't really oxygenate the blood unless you're breathing air in and out, which is considered ventilation. Um, Once we've fixed that issue with ventilation, then we would move on to oxygenation. If they're having trouble receiving enough oxygen or getting enough oxygen to the tissues in their body, then we'd address that issue, either upping their oxygen consumption or oxygen administration. After that, then we look at the circulation or perfusion, the blood flow. Is it flowing correctly to the body? what's going on there. Is there some sort of non-transfer of oxygen from the lungs to the blood? And then lastly, we'd look at any underlying causes. Is there something else going on that is causing the issue we have not fixed already? As we focus on these separate categories, it allows us to fix and find the important things that need to be done so the patient can have the best outcome necessary. So what's really cool is there's a lot of things that we can do to fix each of these categories specifically, and to really give the best outcome for the patient. With ventilation, a lot of cool things that we use is mechanical ventilation. We use actually machines to breathe for these people, uh, to really help them move the air in. Sometimes people can't move the air that they want to, or they're just not strong enough to like breathe in as deeply as they need to. And so we're able to provide machine use, provide the actual breath they need. What's really cool with these machines is that they have so many different settings that we'll go into deeper later, but can customize these machines to fit your patient specifically. Every single person is different. How old they are, how tall they are, how much they weigh, whatever the case may be, you can customize the settings on these machines to meet each person's individual needs. Sometimes people are not able to breathe at all, and the machine has to do everything for them. We're able to make that adjustment so the machine does every single breath for them, in and out, in and out. Sometimes the people are unconscious and they need a little bit of help, and we're able to make that adjustment where they're mainly breathing on their own, and the machine just offers a little bit of support. Sometimes it's a mixture of both, where they're breathing sometimes, but then they're not, and the machine is able to make up for when they're not, which is really cool with ventilation, how these machines allow us to be able to give the patient what they need to survive. Oftentimes it is in emergency situations. Sometimes, and a lot of the times as well, we do use these in like surgeries to make sure that the patient is performing at their maximum level so that they maintain strength during a surgery or whatnot. Another way we do this, with these mechanical machines, mechanical ventilation, sometimes we go in, that I previously talked about, is using a tube and actually being pretty invasive, going down and forcing the air into their lungs, through a tube that's inserted in their throat. We are also allowed to do this without even being invasive at all, just with a simple mask that goes over their mouth and nose and provides pressure and airflow to make sure that they are receiving the proper ventilation. This is used more for patients who might have requested that they don't have a tube stuck down their throat in their advanced directives or whatever the case may be. Can also be used for someone who is still awake and breathing just very heavily and they just need some help and they don't want to shove a tube down their throat. You can put a mask on them, connect them to these machines, and it's able to just assist them enough that they're able to recover and calm down and slow their breathing. Like I said, they have a lot of different settings that allows us to customize them. That can be kind of confusing, but very useful. Very useful. Well, as I already stated, how these mechanic machines help the patients, it also helps us as respiratory therapists to be able to know what the patient's needs are. As was already talked about by Nick, using EBGs, or blood gases are commonly known as, to really find the chemical balances within the body. The machines allow us to be able to manipulate those chemicals through breathing. We can control their respiratory rate, which in a way affects their CO2 levels. We can increase the oxygen through the ventilator or through the machines, to help with their oxygen levels in the blood. So these machines also help us to be able to see how the patient is actually being affected by the machine themselves. Mechanical ventilation through like a tube through the throat, or a mask that goes over the mouth and nose. We also provide care through like tracheostomies in the actual inserted into the trachea, which can be useful if there is ever like trauma on the patient's mouth or some sort of obstruction, or if we know the patient's going to be on a machine breathing for a very long time, we'll often, in most cases, go with that as a means to provide the proper ventilation and care for the patient, just immediately going to the trach. As we've already discussed, ventilation as a strategy to help the patient. The next step would be to improve the oxygenation. Most common way to do this is just to increase oxygen percentage that you're giving to the patient. This is talked about as what we call FiO2. That's just a fraction of inspired oxygen that the patient is breathing in, a fraction of inhaled oxygen. A lot of the times, most patients will just go on like a nasal cannula. You've probably seen people walking around at the store carrying a tank. It's just oxygen they're getting just to help keep their oxygen levels up so that their whole body is receiving the proper oxygen to supply to the tissues and the rest of their body. One way we do this with like machines is we provide support, which kind of bleeds in oxygen so that they're for sure getting an exact amount of oxygen every time, and it's not left up to chance for them to just breathe in a certain amount, but we deliver an exact amount every time. We can also provide means of using pressure to make sure the oxygen is more or less pushed into the patient's body through pressure, keeping the lungs open longer so that they can absorb more oxygen as well. It can be very beneficial and very helpful for the patient as well as for us. Same thing, to make sure that they really are getting the care and the therapy that they need. Next tools that we have as respiratory therapists, one of the things that we do is help assist with bronchoscopes. They're more or less a camera that's inserted to help determine what's going on in the lungs. These are commonly used with children if they breathe in maybe like a Lego or a small toy that gets stuck in their lungs. We can go down with a camera, help a doctor out in finding and locating that and retrieving it and pulling it out of the child's airway to help them breathe a little better. These can be used as well for helping diagnose issues that we can't see from the outside. Being able to see maybe accumulation of fluids or scar tissues within inside the lungs. Just once again, to give the patient the best care that they can possibly get. These tools can be used as a respiratory therapist to really help give the patient the best outcomes and the best care that we possibly can. I'm going to turn the time over to Thomas to kind of continue to talk about some other things that we can use to help the patients out and help ourselves out to make our job easy and to make sure that we give the best care. Thomas, take her away.
All right, thanks, Trevor. So Trevor's talked about a lot of interventions that we can do. There's even more, and it's kind of hard to cover it all in this episode that we're talking about, since the field is also continuously growing. But as Nick was talking about with patient data, this is how we get a lot of our information on how to best intervene for the patient. I'm going to start talking about thoracentesis. This is when you can have like an excess buildup of fluid in your lungs, which pushes on your lungs so that they can't expand as fully as they should. So what they do is they insert a needle to drain that fluid out. Some other things that we do is cardiopulmonary stress testing. This helps us determine certain pathophysiologies like diseases or traumas that could have happened to the patient. It's just another tool that we use to help gauge what interventions are best for the patient. Pulmonary stress testing. This is a test done to test the function of the lungs and heart, usually through an exercise effort. If the patient is unable to exercise, we can perform this test chemically to facilitate a response to see what defects the patient may have. Another way that we can test patients is through sleep testing, which is something I've always thought was ironic. Is what a sleep test is, we hook up probably like 20 wires to a person's head and a couple straps around their belly, and we expect them to sleep normally so that we can, I guess, evaluate how they sleep at home. Nobody sleeps like that at home, so I don't understand how that's an effective test, but that's what we do. It's used to determine whether the patient has sleep apnea and what kind. There's obstructive and there's central. And the difference is obstructive, most people, their tongue or they're overweight, it just kind of pushes on their breathing airway, and they need some pressure, usually given to them through a CPAP to help keep them breathing while they sleep. Central apnea is the brain. It's not sending signals to take a breath while you're sleeping, and that's what that test is for. Other things respiratory therapists do is assist with pulmonary rehab. Home care, which entails oxygen setup and other equipment setup. I bet Trevor has plenty of stories and experiences that we're going to hear about these later on, because that's what he does right now. We also can help with patient transport if you're interested in doing life flight or air med. Respiratory therapists, they help with that. Modes of transportation for this include ambulance, helicopter, or fixed wing aircraft. It kind of depends on the distance that you're transporting a patient. Especially, so I work at a hospital here in Ogden. We get patients flown into us from parts of Idaho and parts of Wyoming. So we kind of get patients from all over that come to us from life flight. We also help with disease management. We are kind of on the front lines with teaching with smoking cessation, which is trying to get people to help quit smoking. Along those lines, we teach patients and families basics on how to perform certain therapies on their own, obviously with supervision at first, and then hopefully they're comfortable enough to do it on their own at home, so they don't have to keep coming to the hospital. Improvement is an example of ways respiratory therapists provide cares at given facilities. We kind of evaluate what we're doing, outcomes of certain therapies that we're doing, therapies that might have been missed. Just kind of a benchmark that we can set ourselves at and how we can improve in our line of work. We do research to utilize evidence-based medicine to ensure we are providing the best care and to keep up to date with the evolution of therapies. Like I said earlier, this field is continuously growing. And hospital protocols, we got to know those, so we act in accordance, so we're all following the same procedures and following a systemic way of performing things, so we're all doing the same, performing cares the same way. Examples of that is ARDSNet and an acronym NAEPP, which is a fancy way of just saying asthma prevention program. Okay. Along those lines, we help patients set up an asthma action plan, which kind of illustrates to patients when they need to call 911, when they should take their rescue inhaler, when they should go to an Instacare versus an ER, stuff like that. And then another thing we're going to talk about is withdrawing life support. So that's usually when we take someone off of a ventilator, which Trevor was talking about earlier, was ventilators. Unlike in Hollywood, when somebody gets the tube pulled out of their mouth, they usually go pretty quick if they didn't go before the tube was pulled out. That's not how I've seen it happen. Usually it takes most people an hour or two after we unhook life support before they have passed on. And that's what we do. And I think that affects a lot of respiratory therapists, feeling like we may have killed a patient kind of thing. But you need to realize that the patient probably would have died if we didn't intervene. Or you also need to take comfort knowing that you're respecting the patient's wishes. In most cases that I've been a part of, the patient was able to communicate in some way, like, I don't want to go on much longer. I'd rather not be hooked up with to this breathing machine. So as respiratory therapists, it may be a hard thing withdrawing life support, but I think you can take good comfort in knowing that it's what the patient wants. So you're just respecting their wishes. It may not be in accordance to what you think is best or what should be done, but in all reality, it's the patient's life, and you should respect what they want. So there's that. Sorry, I got a little serious right there, but along those lines, whenever a patient codes is a hospital lingo for having a heart attack or cardiac arrest, respiratory therapists are there to assist with breathing. While other people are doing chest compressions, we're at the head of the bed, bagging, ventilating the patient the best we can. They don't only take care of adults, we take care of neonates. And that is another animal of itself, which is something we're actually learning about this year in the second year of the program. We also take care of infants, a little bit older than neonates. Neonates are newborns, infants, and pediatrics. regards to babies' effectiveness to breathing, since we are respiratory therapists responsible for the patient breathing, their respiration, and ventilating through a scoring system called APGAR. And I'm sure we will talk more about this later. It's just a scoring system to see, again, when do we need to intervene and how would we intervene. Other factors that play into effect is the mom's history. Has the mom been on certain types of drugs? Has she been smoking during pregnancy? Has she been drinking during pregnancy? Even certain medications that she may be on, like antidepressants and stuff like that, can affect the baby's delivery and the outcome. We just want to consider those things because at a baby delivery, you're eventually going to have two patients in the same room. It's just a fact, okay? And knowing that history can help us better have better outcomes with the baby and how we treat them. Other factors to consider is the baby's gestational age. Again, APGAR, like I said, those are pretty much the two major things that we use to evaluate a newborn. Certain pathologies that could be present, such as two major categories are congenital heart defects. They may have aspirated, which means they may have inhaled some fluids while they were in delivery, or in utero. Sorry, I'm trying not to use medical jargon, but in utero. But respiratory therapists administer breathing treatments by means of an SVN, MDI, DPI. Therapists need to have a working knowledge of medications they give to their patients, but also other medications that the person may have taken beforehand to ensure we get the desired outcome of the patient. Like Nick was saying, we are kind of responsible for, or we assist with the lungs, the heart, and the kidneys. And sometimes medications we give may speed up the heart, may slow down the heart, and we just need to make sure that the medications we're giving work together with what they've already been given instead of kind of counteracting each other or making a good situation bad. We also need to have a working knowledge of diseases that could restrict a person's breathing, be able to discern between obstructive and restrictive. The procedures following these differ greatly on the problem at hand. Many of these interventions have briefly been touched on already. So that kind of wraps up the brief overview of what we're going to talk about with intervention. Next up is going to be Drew. He's going to talk about the equipment that we actually use to facilitate these interventions. So, Drew, it's up to you now.
All right, thank you. So, one of the main things that we're trying to help patients with is through the oxygenation, which is the second keystone of what we try and do. After we make sure that you are ventilating, we want to make sure that you're getting the appropriate amount of oxygen that your body needs to facilitate all the operations it does on its own. And so the one thing that I remember that kind of hit me hard when we were first learning about all this respiratory stuff is that oxygen itself, we consider it a drug, which I thought was kind of weird because, we need oxygen to live, and I figured more the better. But the more the oxygen that we start to give people, the more our body starts to become dependent on that. And in some diseases like COPD, if you just over-oxygenate someone, you'll end up shutting down their respiratory drive and start hurting them more than you were actually helping them. Okay, so I would like to also talk about how we're going to start delivering that oxygen to our patients. And I want to kind of just talk about the less severe needs and go down to when we start needing to help the patient when they start needing more and more oxygen. So the first one I want to talk about is our nasal cannula. And this is probably your traditional thing that you see where maybe you're just in the grocery store or whatever, and you see someone walking around with tubes in their nose. This just helps them with their just basic day-to-day oxygen delivery. We also measure that in percentage, and and the percentage is your air to oxygen ratio. So when I'm saying that we deliver to about 24 to 44%, that's 24% oxygen out of the air that we're delivering to our patient. And that would just be to probably about just your minimum flow, so like 0.5 to about 6 liters is what we would use a nasal cannula. And if our patient starts needing more, we're going to move up to a simple mask. And this will help deliver about 6 to 10 liters per minute to our patient. Again, and that's just more just as we start seeing that the patient needs more and more demand or need for oxygen, that's when we're going to help put that in. And a simple mask is going to help keep more of that oxygen inside the patient because it rests over their nose and their mouth. And it helps them to help retain a lot of the oxygen as they're breathing in and out. And the important thing to remember about that is that you want to make sure that you're not putting anything less than 6 liters into that mask, because if you have anything less, you're not blowing out that CO2, and then they're going to start retaining that CO2 again as they're breathing it back in. And the next degree that we're going to go into is the partial rebreather mask. And this is actually what we call a non-rebreather mask, but it has 2 little flaps on the sides. And a non-rebreather, you're going to leave both flaps covered, and that will just allow the patient to only breathe in oxygen that we are delivering to them, and let them blow out the oxygen or the CO2 that they're breathing off. But the partial rebreather, you leave one of those flaps open, and it allows for more gases to escape as a patient needs get better or worse. And the next one that I want to talk about is your air entrainment mask. And this one is going to be what's also called a Venturi mask, or a high flow oxygen delivery. And this will help you blend in your oxygen needs. It's a mask that, again, fits over your nose and your mouth, and it helps to kind of blend in that oxygen in the air depending on what your patient's needs are. And those are some of the simple equipment that we have to help deliver oxygen to our patients. And as we were talking about interventions, some of the things that we also have are aerosol masks, and this is what you'd see like maybe with the nebulizer treatment, if you've ever seen that before. And again, that'll just fit right over your nose and your mouth, and it helps aerosolize some of your medicine so that it can get deeper down into your lungs where it's actually needed. We also have equipment that will help patients with, say, like a tracheotomy or just they aren't able to use their mouth like they're supposed to, and so we have a surgical incision hole put into the trachea to help them with that air. And we have oxygen masks that will help them breathe through that, that are actually modified specifically for those trachs. As I mentioned before, as we were escalating the oxygen needs for our patients, we break those down into 2 different categories, like your normal flow, which would be about 1 liter of oxygen to about 6 liters of oxygen. And as we start to increase from there, it starts to become more and more of a high flow that we're giving to our patients. So as our oxygen demand starts to increase with our patients, we start to enter what's called our high flow oxygen therapy. And this is considered anything that's above 10 liters per minute that we're delivering to our patient. And the thing with high flow is we got to start being really careful because we're going to be adding pressures into their lungs. We're going to be forcing a lot more air into their upper airway, which could also cause dryness in our patients. Which kind of segues right into the next thing that I wanted to bring up, which is your humidification for our patients. Because as we dry out our patients, it make them feel more uncomfortable. It could cause sores, and it could harden some of the secretions that are in their body or in their airway, and make it harder for them to breathe. So we have a whole bunch of different kind of humidifications that we give to our patients. I'll just kind of briefly talk about, or just mention what we have, and mainly their key thing about what they're doing. For instance, like we have what's called a passover humidifier, which really is kind of just what it sounds like. The air just passes over the water and helps to humidify some of it. But just doing that alone without any heating, it's not super effective. But as you start to heat up the water, it becomes more and more effective. But at the same time, it's not really appropriate for those that are needing that mechanical ventilation. And so the next one that I want to talk about was bubble humidifying. And this works over, it's kind of like the passover, but it goes more in depth, literally. So this is going to have kind of like a little straw that goes down, or a little chamber or whatever goes down under the fluid or the water, and it's going to force that air in at the bottom of the fluid and push it back up, and which will in turn humidify the air that's going into our patient. So the next one that I want to talk about is when we start to encroach in our what's called a heating humidifier, which the first one is the cascade humidifier. And this is going to help our patients that start to have thick secretions, because as we're delivering that high flow of oxygen to our patients, their secretions are going to start hardening, which makes it harder for air and oxygen to pass through. So we want to make sure that we're getting those humidified so that the patient can start to, hack up those loogies or those boogers that start to develop in their airway, so that they can start increasing their surface area that's inside their lungs, so they can start to breathe better. The cascade works by just heating up the device, and starts to help the oxygen to attach better to the air and move better into the patient. And then we have the wick humidifier, which does the exact same thing. We'd only use these for our patients that start to develop those thick secretions again. And it's just like the cascade, but it is most efficient by expanding the surface area of the water droplets to attach that humidification to the air in the patient. The next thing is actually a really cool thing. It's called a heat moisture exchanger. So this is also called a artificial nose, because it works by trapping air. And I should also mention that this is something that we would use on like a patient that's on a mechanical ventilator, that just came out of a post-op, or things like that. But this works by trapping in that heat, like our nose would do. As we breathe in air through our nose, it goes through a whole bunch of passages to help humidify and warm up the air as it goes into our lungs. And it basically does that. It is an artificial device that helps to bring that air into our lungs as if it had gone through our nose. That's pretty cool. These are the forms that we have to help humidify that air so that the patient is more comfortable. The secretions are starting to retain some more fluid so that they can start hacking those up, or we can suction them out, just make it easier for our patient to breathe. The next thing that we are going to talk about is the nebulizers. There's a few different types of nebulizers. And for those of you who don't know what nebulizers are, it's just a form of medication that we can give to our patient that helps break down that medicine, a liquid medicine, into our patient so it can get deeper down inside their lungs, instead of like a powder or a pill. It's designated to go deeper down into your lungs, ride the air that's going down to those lungs. The first form is our jet nebulizer. And this is what you're going to see a lot of, like home nebulizing treatments that some patients will have. What it does, you just hook up this little device and you stick an air hose into the bottom of it, and that pushes a lot of the gas into that device, and that breaks up those particles as they ride down into your lungs, so they can get deeper down, like we were mentioning. The next one is a reservoir jet nebulizer, and this just works a lot with like your large volume nebulizers, where you're needing to give a lot more medication to a patient, and it just is more equipped for those larger doses of medicine, but works similar, but also has to be heated too. With the ultrasonic nebulizer, this is a pretty cool one, because it works by vibrating. It doesn't work by forcing air into it necessarily. That vibrating disc is called a piezoelectric disc, but in our class we kind of termed it as a healing crystal, just because it's super effective, and it just helps to medicate our patients and help them start to feel better. But the thing with that is you got to be aware of how much you're giving to our patients, because we can overflow or overload those secretions and actually cause more damage and cause fluid restrictions inside our patient's lungs. And then we have what's called a centrifugal nebulizer. This is kind of your more least effective nebulizer because it doesn't really break anything down. It just has uniform particles and doesn't really help out as much as the other forms of nebulizing. And then going off of those nebulizers, sometimes the patients don't necessarily need it or need to be nebulized because it does take quite a bit of time. And then we start to get into like our medicines. We have the metered dose inhalers, or MDIs. And this can be either gas, liquid, and it's more just initiated by the patient to help that medicine go into their lungs, but it's not nebulized or anything like that. Briefly mentioned earlier, I believe as Trevor and also Thomas have mentioned, we have those patients that can't necessarily breathe on their own, and so we have to create an artificial airway. We have a couple ways of doing that. First is by inserting an endotracheal tube, or an ET tube. You might hear it because it's a lot easier and faster to say. But there's two modalities to that. The most common is your oral intubation in adults, and that would just go through your mouth down into your trachea and sit right above where your lungs split up, which is called the carina. And then you also have your nasal intubation. I haven't really seen too many patients in my history of working in healthcare with nasal intubation, but it works the exact same way. It just goes through your nose and then down into your lungs. And the important thing is as a respiratory therapist, you want to measure where those ET tubes are, because you want to make sure that it's A, down far enough, or B, or that it's not too far down, because then it can go into a lung and create all sorts of different problems, which I'm sure we'll talk about later on in a different episode. But then you also have your tracheostomy tubes, which completely bypass your mouth and they go straight into your trachea. So if you've ever seen someone that has like a hole in their neck, and that's how they're breathing, that is what that is, and that helps them just completely bypass, because maybe they have, I don't know, swelling in the mouth or like cancer, and their upper airway isn't able to work as best as it should, and so a tracheostomy tube is helping them. The next one, it kind of goes in with your ET tube, but it's called a double lumen endotracheal tube. This one's pretty neat because it has where your normal ET tube, it just has a hole that's at the very end of the tube, which is called a bevel, and that's how it kind of helps. Kind of almost looks like a needle a little bit with that bevel, and that is where it helps to guide in and make the insertion of the ET tube better and more smooth. But the double lumen, it actually has what's called a Murphy's eye at the other side, at the very end of that ET tube. So that way, just in case that bevel gets covered or gets inserted too far, that Murphy's eye is able to help oxygenate the other side of the lung, so that both sides of the lung are starting to get appropriate oxygen that it needs. The next one is a little bit less invasive. It's called a laryngeal mask airway. And so this will just go right by your larynx, and it kind of just inflates and just works that way instead of going all the way down into your lungs. The thing that all of these airways have in common, and at the very end of it, by the bevel, we have what's called a cuff. And at this cuff, we inflate it with air, much like, I don't know if any of you that are listening might know what a catheter is, that urethral catheter or whatever, but there's a little bulb in the very back of that, or the very end of that helps it lock it in place. That's exactly what these cuffs do. They help keep the ET tube from moving anywhere, and also helps the air from escaping, because once these patients get hooked up to mechanical ventilation, we need to make sure that we're keeping as much air in those lungs and pressure in those lungs that we need to appropriately help our patients. the important thing about these artificial airways that I briefly want to mention is that because these are foreign objects that we have inserted to our patients, we're going to start developing secretions that are going to build up around them, whether it's going to be on the outside of our mouth before it goes into our lungs, or the lungs are going to start building up some secretions. So we need to get rid of those secretions because they are going to be, the more they build up, they're going to start impeding the way our oxygen is delivered to our patients, whether or even at all. So we have a lot of suctioning devices that we use, especially if a patient is on mechanical ventilating. One that we have that's pretty cool is a closed suction catheter. And this will just hook in at the very end of the ET tube that is outside of the patient, and then is connected to what we call a circuit, which we'll talk more about later. But this helps keep the patient safe from bacteria buildup or us introducing bacteria into our patient, because it is a closed circuit suctioning, and it's pretty cool. It just starts out this little like hose type thing or catheter and goes right into their lungs, and it helps us to suction out the patient's lungs and get rid of those secretions so they can start to breathe better. And then we also have your standard catheter, or your standard suctioning, I'm sorry. And this will just help to suction out the top of the mouth right above the trachea, and because that will start to build up and cause other problems there. So we have a lot of devices that help us to help our patients breathe better, get oxygen. And I just briefly mentioned some of the stuff that we have to do that in our wide range of equipment that we have in our utility belts as RTs. But now I'd like to just turn the time over back to our friend Nick.
Well, thank you, Drew. That was it was a pretty long explanation of what respiratory therapists do, what we have available for us, and what we're kind of dealing with day to day. But it shows just how advanced the field is and how we are right on the front lines as respiratory therapists. We are there along with the nurses, along with the physicians, engaged in huge amounts of patient care. And that the job that respiratory therapists do is just as important as those jobs. We fill a special role that nurses know how to do some of, but they aren't as in depth as us. And while physicians may be able to do our work, they're much busier with larger problems for the most part. So we are really the lifeline for our patients. We are the ones that are there day in, day out, making sure that they can breathe and that they can live. Now, thank you for listening to the pilot episode of Don't Hate, Ventilate. I've been your host, Nick. See you next time.